Good day and welcome to the regional community workshop put on by the International Myeloma Foundation. We are grateful that you are all here, and we have a really good presentation by two of my favorite doctors, sorry about that have been involved with myeloma for many years. You'll see that they'll be presenting, and then we'll have a Q&A after, and we will go back to the next presentation, and then we'll finish up with the Q&A too. So you have multiple opportunities to ask the questions. Please feel free to type those questions in the chat box, and you'll get the information that you need to ask those questions. Next slide. We couldn't do this without our sponsors that have helped us throughout the years, and that is Amgen. I'm having a problem reading this right now, sorry. Amgen, Bristol Myers Squibb, GSK, Janssen, Takeda, Karyopharm, and Takeda Oncology, sorry. Now, the next slide, please. You'll see in your window a question type prompt, and that's where we want you to put your questions. And you're also going to get a survey about this program after, and we'd really appreciate that you'll participate in this, due in part that this is how we get the information to help future programs. The IMF puts on over 40 meetings a year throughout the world, and all of the people that participate in that are all very important to us to get the information to you as an end user to help you through your process of myeloma. The agenda is pretty simple here. We start with my welcome, then you go to Myeloma 101, then we take a little Q&A, then we take a little break, then we go into my clinical trials and relapse, and then we go into supportive care, and then we have some more questions, and then we take a break, and then you guys can go off on your Saturday and do what you normally do. I'd like to introduce our first doctor who is going to be going over Myeloma 101 and Frontline therapy, Caitlin Costello, an MD at University of California, San Diego. Caitlin helps out several support groups in Southern California, so I'm really honored here that she's able to participate on this Saturday. Caitlin, will you take it away for me?
Absolutely, Kelly. Thank you so much, and greetings to you all. Thank you for spending your part of your Saturday with us. I'm delighted to be here, and we'll just review a little Myeloma 101, and before I turn it over to my colleagues to hear about more goodies in myeloma. So without further ado, there's a lot to cover here. Bear with me. I just want to make sure we touch on as much as we can. So Myeloma 101, let's get started. Well, myeloma today, we know now it's the second most common blood cancer that's out there, where it looks like there's close to 100,000 patients living in the US with multiple myeloma. And that competes with other non-Hodgkin's lymphoma, for example, as one of the blood cancers that is most common. Why does myeloma happen? Well, not quite clear to us yet. We wonder if there's an inherited risk, but when it comes down to it, you know, my slides are advancing without me, Kelly. I don't know if you have any magic to stop that, but bear with me as we figure out our slides. We don't know for sure. There was a study that was done that maybe suggests that there could be a small increased relative risk in some patients, but overall don't have a great understanding as to why multiple myeloma happens. And so a quick plug I'd put in for the PROMISE study, which is looking at family members of patients who have been diagnosed with multiple myeloma. I'm sorry, my slides are just moving here. The promisestudy.org, you can look it up. It's free for you for undergoing screening for any African-American or any person of any race who has a parent, a sibling, or a child with multiple myeloma or any form of a blood cancer, looking to see if we can find any myeloma or related conditions to get a little better understanding of what may be that risk or the inherited risk, or if we can get any other information about families that are more likely to have had this. So if it isn't an inherited risk, well, what is it? Well, I guess the answer is we don't really know. We wonder if there's environmental exposures, patients who have had exposures to Agent Orange as an example. Sorry, we're just skipping. Okay, thank you. We know that the risk increases with age. We know that there's a little bit more of a predisposition in men, and particularly in African Americans, where there looks to be about a twofold increase of developing multiple myeloma. We don't know, maybe there's occupational exposures, patients who have worked with chemicals, pesticides, those are other kind of hypotheses are out there, but ultimately hard to say. We don't have a good sense of why patients eventually develop multiple myeloma. But what we do know in 2022 is that about 35,000 new patients are expected to be diagnosed this year. And you can see there, the rate of new cases is slowly increasing, but you can see that patients, the rate of death associated with multiple myeloma is decreasing over time. So we have more patients being diagnosed, but more people who are living with it. And this has a lot to do with all the new medicines and the successes of several of our drug combinations that are happening and occurring out there. And so we can see that people are surviving after having had this diagnosis for longer than ever before. Well, what is multiple myeloma? Well, very broadly, let's think of that your bone marrow is the factory of your body's blood and immune system. Part of your immune system is a cell called a plasma cell. The plasma cell is responsible for making antibodies. Now, these can be antibodies that are around fighting COVID or fighting a pneumonia or flu or whatever it may be. These antibodies, I like to think of them as weapons that are there to seek and destroy the bad guys. Well, for some reason, we know that these plasma cells go rogue. And when they go rogue, they start making these weapons that are not as effective as they should be. Not only are they not effective, but they start copying themselves. And they make these proteins you can see on the far right side there, the light chains and the heavy chains. You'll hear a lot about that. We'll talk about it in a little bit. But it's important to understand it's this form of the abnormal protein that's being produced incorrectly that is the source of all the damage that is happening to a patient's body with multiple myeloma. Well, so how do those abnormal proteins affect your body? Well, we like to think of it kind of traditionally as this crab criteria. So historically, we've said if any of these criteria are met after you have had a bone marrow biopsy that shows that you have these abnormal plasma cells in your bone marrow and you have any of the hypercalcemia, which means your calcium levels in your bloodstream are elevated. Hang on, bear with me. The calcium levels can be increased in a handful of patients when they're first diagnosed. This can have to do with kidneys being irritated. This has to do with bones being affected by myeloma. The way I like to think of it sometimes, just for simplicity's sake, is I like to think of these proteins as kind of like little Pac-Man. When they end up in your bloodstream after being produced in the bone marrow, they kind of run around in the body and look for places to wreak havoc. And the places that they traditionally like to do that is number one, bones. Like little Pac-Man, sometimes they take little bites out of those bones, and we call these lesions. They literally look like little divots in the grass when we're looking at them on X-ray. A great majority of patients, when they're first diagnosed, can present to their doctor or an emergency room and say, I've got this pain, it's not going away, help. And what we can do is when we do x-rays or pictures, and we'll talk about that, we can see that there are these little areas that have had little bites taken out of those bones. Sometimes those bones then can affect the calcium levels. And when the bones are being affected and damaged, it can release some of that, and let's call it calcium, into the bloodstream and find those calcium levels being elevated. The other ways that this can affect the body is renal failure. So that's our fancy doctor term for kidney problems. And what I like to think of as happening is sometimes those proteins are being produced in such excess. If you think about your kidneys as part of a major kind of plumbing system in your body, sometimes, kind of like my silly analogy is hair in the shower drain, these different proteins kind of get stuck in the kidneys, and they're trying so hard to get rid of all this extra protein that's in the bloodstream. Sometimes they get clogged up. Those pipes get clogged up. That can really irritate the kidneys as well. And so you can find that normal kidney function, and we check this on your routine blood test, can suddenly be abnormal as well. And then A is for anemia. So anemia means that you have low blood levels. Now, why does that happen? A couple of different reasons I like to think of. One is that if your bone marrow, your factory of your body's blood and immune system, is so busy making the bad guys, maybe there's just not enough room in the inn to make the normal blood that you need. Sometimes also your kidneys are an important part of telling your body that you need blood. And if those kidneys are so irritated by those extra proteins in your body, they cannot do their job to tell the rest of your body to make the blood that you need. And so patients can present with, as their initial diagnosis, to say, hey, doc, I feel tired, I feel weak, I feel short of breath, I feel dizzy or lightheaded. This is a very common symptom when patients are first diagnosed. These are our kind of historic and more traditional criteria. But what I like to think and say, and Dr. Joe McHale likes to say, is at the point that we get to this, a lot of damage has already been done to the body. And why do we have to wait for people to kind of jump off that cliff before we say, this is myeloma, you now have that diagnosis because you have one of these criteria? Are there any signs or anything we can look for before any of this damage has been done instead? And we'll talk about that a little bit. Moving forward, I want you to understand, however, the myeloma doesn't happen overnight. When myeloma starts, it is something that has been likely brewing in your body for some time, and that may be years. We know that it's a spectrum of disease. It's on one end of the spectrum where you have multiple myeloma, where it's affecting your bones or your kidneys. But it didn't start yesterday. It started as one cell that went rogue, that copied itself, which turned into 2 cells, which turned into 4 cells. And so what you can see is there's this progression where the M protein is what we're talking about, the myeloma protein, the abnormal protein, starts at 0. Over time, it may develop where you now have a few of them that are there, but you don't feel it. It's kind of percolating in your body and growing very slowly. Your kidneys are working fine. You haven't reached that tipping point where it affects the body. And this is a syndrome, or I should say a classification of the disease called MGUS, monoclonal gammopathy of undetermined significance. Means we know there's a little there. We don't know why. We don't know if we care. But we know that everyone who has myeloma eventually, or I should say, started off with this diagnosis. So if you have MGUS on one end, you can progress down that spectrum as the amount of the protein grows in your system. Ultimately, however, as it continues to grow, eventually that bad guy cell will reach a critical mass where it now is affecting your body, and we would diagnose at that point multiple myeloma, which we would say requires treatment to prevent further damage from happening. So as I mentioned, if we are now waiting, historically have waited for people to have kidney failure or bone damage, is there anything we can do to try and anticipate that advance, to say, who can we kind of save from jumping off that cliff? Are there people for whom which there are information to say, you're heading in the wrong direction? How can we redirect this train before it causes more damage to your bones or kidneys, as an example? And there was a study that was done that said, yes, there are a couple of bits of information. So for all of you who have done a bone marrow biopsy and know how pleasant that is, it does give us a lot of information. Historically, we've said 10%. If it is 10% full of bad guys and you have kidney damage or bone damage, that's multiple myeloma. But there are plenty of people who have more than 10% there and don't have any bone problems or kidney problems. What about those patients who have 30% or 50%? People who look like they are heading in the wrong direction, but fortunately have not had any effect on their body. What we know, as an example, you can see on the far right over here, for those patients who had more than 60% bad guys in their bone marrow, they had a significantly higher risk of turning into multiple myeloma or having a kidney problem or having a bone problem in the next 2 years. It is about an 80% likelihood. So if that's the case, this is a very obvious group of people that we should say, hold up, this is heading in the wrong direction. Can we start treatment on someone like that sooner rather than waiting for end organ disease or more permanent damage being done to the body? And so we now, instead of just following CRAB criteria, have developed a set of more objective criteria that says, if these specific things happen, although your body is still healthy and feeling well, we worry that this is heading in the wrong direction. And at this point, it is worth it for us to initiate treatment to prevent any of that damage from being done. So here is how we kind of look at that spectrum. So on one side, that MGUS means that you have that M protein, that's less than 3. You have a little bit of that protein that's there. We did a bone marrow biopsy that shows that it's only 10%, or I should say less than 10% full of bad guys, and no myeloma defining events. Your kidneys are happy, your bones are happy. This is, in theory, a benign condition, but we know that it has a risk of growing into multiple myeloma over time. So if you've been diagnosed with MGUS, you and your doctor should have a plan for monitoring to make sure that you do not end up working your way down this spectrum. Now, there's that middle ground called smoldering myeloma. Now your body has started making a little more than just a little bit of that protein, where it's kind of the middle ground between a little bit and a lot. And so smoldering myeloma is a whole other topic in and of itself. But broadly, we'd say you have some critical mass of the abnormal protein that's there, not that meets any criteria for a formal diagnosis of multiple myeloma, no end organ disease, no bone problems, no kidney problems. But now we're getting a little more worried because it looks like the amount of the abnormal protein in your body is heading in the wrong direction. This is a time point where we really need to understand how and who is going to be at highest risk of turning into multiple myeloma the soonest. And this is a huge area of research right now, trying to understand who should get treatment at this point and who we can keep watching. And that brings us to multiple myeloma, which I'll spend obviously the rest of our talk about, which is now as a definition defined as anybody who has more than 10% kind of full in their bone marrow and either has damage that's already been found or has those specific criteria we talked about, such as a bone marrow that's so full of 60% more of bad guys, or we did some kind of very high-tech imaging and looked at your bones and said, ooh, I don't like what that looks like. Something that basically is hinting towards the direction of multiple myeloma in the near future that we want to stave off. So you now are on your journey to say, I've just been diagnosed with multiple myeloma. What's next? And this can be a very scary time and a complicated time where you are suddenly learning a whole new language about plasma cells and my M spikes and proteins. So I want to give a little bit of a journey or a map on this journey so you can understand how to best help yourself or your family member if you've just been diagnosed. So things that we'll talk about in our key steps to your journey is you must know your lab tests. Ask questions so you can understand, well, what stage am I? What am I to expect? Get a second opinion. I will tell you that there are some of us that only do myeloma all day, every day. Of all the cancers that are out there, this is all I see 99% of my day. And I'm still learning. Every day I learn something new. And so I encourage you to look for an opinion for someone who does this all the time, because there are lots of oncologists who are brilliant out there in the community who are somehow able to take care of all kinds of myeloma and cancers, but I don't know how you kind of keep up with everything. So I think it's nice to have kind of a myeloma specialist kind of on your team to help guide. Talk to your doctor about treatment, and then talk about what's coming up down the pipeline. So you always kind of have your foot kind of knowing what's coming in the future. Okay, so let's talk a little bit about diagnostic workup, because I need you to understand what these mean, because your doctor can rattle off numbers, but it may mean nothing to you if you don't know what we're talking about. So when we are talking about an SPEP, this is how we use your blood test to tell us how much of the bad guy protein is in your bloodstream. It would be cruel and unusual to do bone marrow biopsies on you all the time to kind of see how things are going. So instead, we can do a blood test to see how much misbehavior is happening from what's in your bone marrow. So if your bone marrow is making that abnormal protein, let's just check the protein in the bloodstream so we can get a sense of how much is there, because it will go up as the bone marrow is misbehaving. It will drop down as treatment kills the bad guys in your bone marrow. So the SPEP is a way that we measure the M spike. The M spike is the most important blood test for 80% of you. It is the sole number that will tell us how much is there and how our treatment is going. The UPEP is another example of a test that is maybe becoming a little bit more outdated, but a way that we can quantify how much of the abnormal protein is in your urine as well. A complete metabolic panel is a blood test that we will almost always do along with the CBC to test your kidneys and your liver and your calcium levels so that we can make sure that they are staying in the normal range when you're at least first diagnosed or through your treatment. The CBC lets us understand if you have anemia. The free light chains, this is part of the protein. There are a lot of different kind of subtypes of myeloma that are out there, and it's important to know which subtype you are. I think I have some slides coming up on that a little bit, but you hear alphabet soup. We say a lot of letters like IgG, IgA, IgM, and kappas and lambdas. These are all different kinds of proteins that can be abnormally produced by your myeloma. Your myeloma will produce one particular combination of proteins. You need to know what that is, because every time you get your blood test done, in the midst of treatment, we may be checking that to get a sense of how successful the treatment is. And so this is a good way for you to track your progress as well. A bone marrow biopsy we always do when we're making a diagnosis that helps us understand where you are on that spectrum of MGUS or smoldering or multiple myeloma, but also is an important way for us to understand how we can prognosticate to some degree. It gives us some genetic information about your myeloma. Now, I'm not talking what mom and dad passed down to you. I'm talking more specifically about the DNA inside the myeloma cells. We know there are a lot of mutations that are associated with multiple myeloma, and we can group those different genetic abnormalities into different risks to say, this one tends to act more stubbornly, or this one tends to act less aggressively. Helps us to some degree help you understand prognosis. So know your labs, know these, ask these questions, I have so many, I don't know what it is about myeloma, but I have so many engineers as patients, and they have these spreadsheets that they write out. And I'll tell you what, it's a really great way for you to track your progress just the same. If your hospital, your doctor's computer system has a patient portal that allows you to graph it, nothing tells a better story than a picture. If you can graph your M spike at the time of diagnosis and watch it improve during your treatment. So know your blood test so that you understand what we're looking at. This is an M spike. I'll just kind of quickly go through it. On the left is a normal M spike. This is a way that we are looking for abnormal proteins. Each of these little, on the A panel on the left here, I don't know if you can see my arrow, but this one little spike up here is a normal protein that's always in your body. This measures little normal other proteins that are there. You should have one big normal spike. On the right-hand side, you can see that the normal spike is there, but oops, what is this other spike over on the right as well? This is literally a way that we quantify how much of the bad guy is in your system. So when we talk about M spike, this is what we are looking at kind of behind the scenes to get a sense of how much is hiding in the background. Then we can understand, not only quantify how much is there, but get a sense of what kind it is. So we can say, is it an IgG subtype? Is it a kappa subtype? Is it a lambda subtype? This is a way for us to say, this is your type of protein. This is what we are following, and we can quantify and check to see how it's going away with treatment. I'm going to keep moving along here because I feel like I have so much to cover and I'm making not a lot of ground here, and I want to get to treatment. So, know your imaging test. So there are a lot of ways that we can take pictures of your body now. The old gold standard of x-rays is, I'll tell you what, in 2022 is kind of gone now. Realistically, I think we are just in too high-tech of a time to just rely on x-rays, which sometimes require you to squint or look backwards or sideways to see if you can really see something. But why do that when we have MRIs and CT scans and PET scans, all this fancy technology that allows such better, clearer views? So when you're first diagnosed, your doctor is going to want to take pictures of all the bones in your bodies. I would make an argument to say x-rays are no longer a good enough picture. You must have something more higher tech than that. So make sure that you are talking to your doctor about getting a whole body CT scan, a whole body PET scan, MRI, whatever that they have at their disposal to use for you. We need something to understand all of your bones. And so your bone marrow test, I mentioned, this is how we do it. We literally have this little needle that gets stuck right into the top of your hip bone on the back. And that's where the juiciest part of your bone marrow lives. In there, we can quantify how much the myeloma is filling up in there. We can do that genetic testing to look at the chromosomes just of the myeloma to get a sense of how we expect it to anticipate, or how we can anticipate it to behave in the future. This is critical information for prognosis. Because we can put all that information into staging. Now, I always tell my patients, do not compare your myeloma stage to any other cancer stage. Every other cancer stage has stage 1, 2, 3, 4. We don't have 4. We don't have anything that relates. Cancers are usually staged based on where they start and where they move to. Lung cancer starts in the lungs and moves somewhere else. We're talking about blood here. It's already everywhere in your body. And so if that's the case, we use a whole totally different staging system to understand how it has affected your body. And there are very specific markers that must be checked when you are first diagnosed, so we can understand if you're stage 1, stage 2, stage 3. And your genetic abnormalities from your bone marrow biopsy get incorporated into this so that we can make that full assessment. And so how aggressive was my myeloma? This is all the information we put in there to understand if you have a standard risk or if you have a higher risk. And there are some specific genetic information that can put patients into higher risk categories that tell us that we may anticipate your myeloma to act more aggressively than someone else who doesn't have that. So ask about your genetics, your chromosomes, to understand that information. So how do we put all this together? Well, we need your blood tests, your urine tests, your bone marrow biopsy tests, and your pictures, so we can kind of basically make a whole treatment plan and a map for you. And so when we're thinking about the approach to treatments, we broadly would say, if you have MGIS after all that testing, you fit into the category on that side. For the most part, we are saying outside of clinical trials, this is a benign condition that does not require treatment and can solely be observed. If, however, you meet the criteria for smoldering multiple myeloma, as I mentioned, this is a little bit more of a kind of controversial topic where you're going to get lots of different opinions on this. I would recommend that anybody who has smoldering myeloma who is thinking about wanting to talk about treatment, look for clinical trials and participate in that so that we can get a better understanding from patients like you whether or not treatment is going to help everybody. Lastly, when it comes to active myeloma, we have diagnosed you with multiple myeloma and we have made the decision that you should get treatment. That's when we're going to think about and talk as a group, you, your family, your doctor, your local oncologist, your expert myeloma specialist, so that we can come up with a good plan that's tailored solely for you. Now, unfortunately, we haven't figured out how to cure myeloma, but I'll tell you, we're getting pretty darn good at controlling it. What we know is myeloma is a disease that's going to come and go. I think about this as a marathon. There's going to be a time of Boston Marathon where you're climbing Heartbreak Hill, and there's going to be times when you are in cruise control, just on flat ground, cruising along. But what we do know is that as it comes, you get treatment, it goes away, it stays away. We want that remission, that stay away period to last as long as we can, because eventually it's going to relapse. And one of the things that we worry about is with every relapse, sometimes myeloma changes, can become a little bit more smart. And when it comes back, we get treatment, we make it go away. We worry that every subsequent remission gets shorter and shorter and shorter. So one of the more kind of recent approaches to treatment from the get-go is put your best foot forward so you can get the best, longest remission you can with the first remission so that every subsequent one can be long as well. So remember also, there are very specific criteria that we can measure your response of or the success of how treatment is going. If the myeloma started at 100 and it decreases by 50%, it's a partial response. If it decreases by 90%, it's a very good partial response. If it goes away 100%, we call you a complete response or a stringent complete response. I tell you this more just so you know that there are specific kind of grading that we can understand just how much myeloma is in your system left over after treatment and how successful the treatment has been. And I very briefly would touch on something called minimal residual disease. This is kind of the new cool cutting edge thing that I would argue is not totally for everyday standard of care treatment, but it's something that is becoming increasingly clear. I can measure the amount of myeloma in your bloodstream. I can measure the amount of it in your bone marrow with kind of my basic technology testing. But in this high-tech day, there is so many other ways that we can count even the one smallest little baby cell that's hiding in the midst of millions of cells way under the surface to say, there's one left over. And where it's becoming clearer and clearer to say that every single cell that we kill off is going to let the remissions last longer. And presumably, the longer you're in remission, we assume the longer you're going to live. And so it's becoming increasingly clear that we need to kill as much as we can. And so why does that matter? Well, look at this. I don't want you to cross your eyes over all these graphs, except for to say is that if we look at patients who are MRD negative, meaning that we counted millions of cells and did not find a single one. No matter if you have those high-risk cytogenetics or those good risk cytogenetics, if you look on the right-hand curve over here, you can see that the patients who have MRD negative, which are the red line and the blue line, no matter if you have high-risk aggressive genetics or not, you're going to do better than someone who still has some myeloma hidden under the surface. You are going to live longer. And so there's more and more of an interest of how can we kill off every single little last cell that's there. So we've kind of gone through this a little bit. We want to talk about myeloma. That's kind of myeloma 101 summary. And then my last 10 minutes, I want to just very briefly kind of touch on some treatment, because this is a real moving target where lots is happening, and it is a really exciting time. I love showing these timelines, and I'll tell you, I've taken about like 20 years of drugs out of there because there's just too many to put on there. But you can really see, look at these, just in the last couple of years, we've had so many new drugs approved, and that is what is changing everything in myeloma. If we talk about remissions being so durable, the goal of treatment, I tell my patients, is to kick the can down the road. We are desperately trying to get you into remission, keep you there so that all those way smarter people than us who are doing all the studies, like my colleagues are coming up next here, are going to basically say, I got the next newest and greatest thing ready for you for when your first relapse happens. That's better than anything else we have now. So all things being equal, there is so many cool, exciting, extremely successful medicines that are coming from multiple myeloma that are changing everything. And so when you're thinking about the kind of myeloma drug arsenal, we have a lot of different kind of classes of drugs that we like to combine into one cocktail for you. And all these different colors here that are on the screen, we basically oftentimes choose 1, 2, 3, 4 of them and put them together as a cocktail. This has been a moving target. We used to say 2 drugs is enough. And then we said, yeah, we did a study, looks like 3 is better than 2. And now in the last year plus, we've been kind of seeing that probably 4 is better than 3. I like to think of it as like the old game of Clue. It's like you want to hit it with a candlestick and a lead pipe and a revolver. If you hit it from every which direction, you're going to have more killing of your myeloma. And so these are the different groups of medicines that we put together to kind of understand how we can best kill your myeloma. But when we're choosing your cocktail, we are choosing it specifically for you. We are looking at your health. We're looking at your energy, your performance status, we call it. How independent are you? Are you able to drive yourself around? Do you do all your laundry and cooking, or do you get tired easily and it's harder for you to care for your home or care for your family? Do you have support? Do you have family who can help you, people who can drive you? Do you work for a living? And I guess nowadays we're going back to this. Do you travel for a living? Do you need pills? Are you capable of getting infusions? How are your veins? What side effects to drugs are deal breakers for you? Doc, I'll do anything as long as I don't lose my hair. Or I'll do anything as long as I can continue to play basketball on the weekends, or whatever it is. Part of choosing a drug cocktail for you is having a conversation with you and your doctor so that we can put things that are related to you, your life, combine it with factors of your disease. Do you have kidney problems? And this particular medicine would be safer for your kidney than that one. Is your myeloma more aggressive than someone else? And that tells us that we need to be more aggressive back and choose more aggressive medicines. Do we need to think about any side effects, for example, that, as I mentioned, may be deal breakers, or say you already have neuropathy from bad diabetes? We don't want to make that any worse. How can we choose drugs that will, again, only let you get and feel better without making anything under the surface kind of come to light more? So there's lots of things that we take into consideration when we are choosing the best cocktail for you. And I think for the sake of kind of moving along, and I know that you're going to hear from one of the next speakers about all the different drugs and side effects and how to take care of yourself during that. So I don't want to steal anyone's thunder. So I'm going to push forward and just talk about something that I'm very excited about broadly, to say, historically, when we have talked about treatment, we look at a patient and make a decision about whether you are eligible for a stem cell transplant or not. A stem cell transplant is an aggressive therapy that is not for everyone, but has historically shown really great remissions, and at least historically shown that people can live longer by doing it. Now, modern studies are always trying to ask the question of, do we still need to do transplant? And I would argue, and I think so many of us who are, disclaimer, I'm a transplanter, I am biased, still believe that there is a very important role for transplant here. But when you are first met by your doctor, that's going to be one of the first questions, is to get a good understanding about whether or not your body is strong enough to undergo a transplant. That helps us make your general treatment plan. That, and everyone, regardless of that decision, starts off with some amount of treatment in order to make the myeloma level go from high to something low. A transplant is an opportunity, as I like to say. Many of my patients, if you're on here, hear me say it's like a 1-2 punch. Kick it while it's down. For patients who go to transplant, they would go after some treatment when we've knocked it down, and then go on some amount of maintenance to keep it down. For patients who decide not to go through transplant, or for whom the decision is made that it's not the right move for you, those patients still get very good therapies to make the numbers go down as low as we can, and then transition directly to some kind of continuous therapy, as I like to say, to keep a lid on myeloma so we can keep it down in remission as long as possible. A brief comment on transplant, just for the sake of semantics. Autologous transplant is when you donate to yourself. It is the most common form of transplant used for multiple myeloma. There are rare instances where we sometimes think about using a donor transplant for you, but this is becoming less and less common for multiple myeloma. The general approach to myeloma and transplant, what it is it's an opportunity to give your body a dose one time of strong chemotherapy. We do that in an attempt to kill off your bone marrow and any bad guy that's in there, but unfortunately it takes all the good guy cells with it. And so part of the transplant is before you get chemotherapy, we remove the seeds of your bone marrow. The seeds of your bone marrow don't have myeloma in there, but they are the seeds to your garden. If we can take those out, we can protect them before you get the chemotherapy, which kills everything else off. We then put those seeds back into your body, and they replant your garden, allow all the normal things to grow back. That is the general gist of the transplant itself. A much longer conversation is needed to understand why to do it and what the risks and benefits of doing it are. But broadly, it's an opportunity to try and get rid of every last myeloma cell that may be hidden under the surface. Now, I want to talk, because this is a very exciting clinical trial that finally was just published just in June now, that is our kind of more modern transplant trial to say, can we do transplant later? There's a lot of patients that are out there to say, no, I don't really want to do it now. I prefer to do it later. My historic argument to that is to say, well, you ain't getting any younger, which means that you're not getting any healthier either. But now we finally have some information to say, if you're thinking about transplant, it is an option to do later, but as long as you understand what you may be leaving on the table, I should say. The purpose of this trial was to say, let's give everyone some treatment and do transplant now, or give the other group treatment now and transplant later, to see if there's any difference between holding off on the transplant until later. And what you can see is the red line is the patient who underwent transplant after their initial treatment. The blue line is patients who chose not to proceed, or I should say in this trial were randomized to not get transplant. You can see that there is about a 20-month difference in the remission time for those patients after in these two groups. So close to 2 years longer of remission time, kind of with modern medicines. When you look at those patients who underwent transplant again and looking at them by MRD, remember that minimal residual disease status, looking for that one little cell hidden under the surface, it was clear that those patients who underwent transplant had a much higher risk of getting to MRD negativity, to killing off that last little one. And we think that means that people are going to stay in remission longer as well. Now, what was interesting about this trial is it still looks like after, 7 years of follow-up, that a transplant does not seem like we are saving lives yet. We are seeing that patients are still living just as long by doing or not doing the transplant. One argument you could say is maybe we just need more time to see if these curves separate a little bit. But it does say that it does offer people who do not want to do a transplant because they're worried about side effects or they don't have the support system to do it, that it is okay to delay transplant or not do it, I would say. The next kind of new thing in my last few minutes here is we had a great cocktail we used for years, which was a combination of lenalidomide and bortezomib and dexamethasone. And we have this drug that's been out there for the last many years called daratumumab. And it looks like it's just the drug that keeps on giving, the gift that keeps on giving. And it was studied and showed such good effectiveness and such success in its early days that we finally got to the point to say, well, why are we holding this until later? Why don't we give it to people when they're first diagnosed? And so this was a trial that said, let's give everybody 4 medicines and compare it to the typical 3 medicines. And let's see if 4 medicines with this daratumumab medicine changes anything. And this is the Griffin study that was recently published. And what you can see is that those patients who got 4 medicines instead of 3 had much overall improved response rates. We killed off many more cells kind of hidden under the surface than with those patients who did not get it. And so this is really becoming a bit of a more standard of care. And you can see that after this is just a handful of years of follow-up, these patients are still across the board with either group still just doing so well. But you can see that they're starting to prove that the patients who got 4 drugs overall are staying in remission longer than those who got just the 3 drugs. And so this is really kind of, I think, becoming a bit more of a standard of care that many of us are choosing to use these 4 drug combinations instead. But not everyone can tolerate 4 drugs. Still, sometimes our older, frailer patients, 4 drugs is a lot. 4 drugs means more success, but 4 drugs does sometimes mean more side effects. And so there are plenty of patients now who are saying, let's just stick with the 3 drugs, but let's use that same medicine, that daratumumab, and use it when you're first diagnosed as well. And this has changed everything for those patients. We are seeing patients living longer than ever before who have not been able to get a transplant, but now are getting daratumumab as part of their initial treatment. We are expecting and anticipating these patients are going to stay alive many-fold longer than we'd ever seen before by using these medications at the time of their diagnosis. I'm seeing my clock kind of tell me that I'm ending up done. So one quick word on maintenance. I loved this slide recently. I saw a talk. Why in a disease that we cannot routinely cure would an effective treatment be stopped when a remission is achieved? Think of this as the lid. Keep the lid on your myeloma. This is where Revlimid maintenance, as an example, after a transplant, or if not a transplant, continuous therapy, staying on some amount of treatment, is relevant and important in order to keep your myeloma under control. And with that, I'm going to just kind of summarize here to say the goals of frontline therapy. Talk to your doctor about whether 3 or 4 drugs is right for you when you're first diagnosed. Think about all the factors we talked about that help you make a good decision and a good treatment decision together about what is the right treatment for you. Remember that anyone who's a candidate for transplant should be evaluated. Please ask for the referral to a transplant center so that you can be evaluated for it, so you can make that discussion and have an informed discussion and decision for yourself. And remember that maintenance matters. There are side effects and there are costs and there's lots of things associated with it, but very few things this day and age have shown an overall survival benefit. I will stop. Thank you. Oh, that was a whirlwind.
Wow.
Setting up with me. I'll take questions whenever Kelly tells me to.
No, that was fantastic. Thank you. Thank you. We got a couple of questions here, and I'll do my best to get them out to you. Is it possible to have liquid biopsies from regular blood or serum to find myeloma markers such as NGS and NGF?
We are trying. We don't want to do bone marrow biopsies as much as you don't want to do bone marrow biopsies. It would be so much more easy for us to do this. I would say that it's always a work in progress. So far, not so good. We are still kind of relying on the bone marrow biopsies to do that, but we are still kind of lots of studies ongoing to see if we can find that for you.
Fantastic. Yeah, this is kind of a personal question. Let me see if I can not make it so personal. They are in their 4th week of RVD DARA induction therapy. And if the neutrophils are falling, is that good, or how serious is this? So
what's broadly being asked here is we've now had patients getting 4 drugs. So 4 drugs together means more success, but also means more toxicity, more side effects. And one of those can be a weakened immune system. So what they're talking about with neutrophils are kind of your important fighter immune system cells have lowered to a level that's lower than normal. And this is a very common side effect that we see and sometimes requires for medicines, Revlimid, for an example, to be held so we can get those neutrophils back up and strengthen your immune system. Sometimes it takes modifications of the dose because maybe the cocktail together has too strong a doses for your particular body. We don't like your neutrophils to be for long periods of time. Long-standing low neutrophils, as you mentioned, can be dangerous. So it is important for you and your doctor to make some modifications so that we are not maintaining levels that low, but are finding doses of the drugs that can stay effective, but not cause your immune system to be so weak.
I don't know, some of us might have an old stereo. It seems like you're kind of going, well, here's the balance. We'll add a little bass to it, bring the treble up, and go through some different programs, phonograph, tape, or whatever. For those of you who are on a what do you call the things? iPod or something? You have no idea what I was just talking about.
Kelly, it's a great analogy, though. I mean, if you're talking about a disease that we cannot cure, the whole strategy is balance. We want to have successes, and we want to balance that with quality and quantity of life as best as we can. And so we need to have successes, but not let you get sick. I always say I never want the treatment to be worse than the disease. And so it's a matter of making modifications and tweaks to find that special balance.
Well, what if a patient has non-secreting and what's the best way to follow it? There's no protein in the urine. Is that a complicated question there?
A little bit. The great majority of patients have some marker that we can follow in order to understand the successes of treatment, whether that's blood tests, urine tests, bone marrow biopsy tests, PET scans. Most of the time, the non-secretors means that their myeloma is not producing any abnormal protein in blood or urine for us to follow, can oftentimes have bones be affected. And with PET scans or serial pictures of their bones, we can see improvements of the bones to kind of gauge the successes of our treatment.
Well, this is a question for Dr. Krishan. Considering a change from Darzalex, I always get that one wrong, and Dex to Kyprolis, Polymus, and Dex. PET scan shows enlarged heart. Does this type of thing, is it temporary, or go see the cardiologist as soon as you can?
Yeah, I mean, I think just again, sort of that, because I make this a more broader general question. What someone's alluding to is there a concern for cardiac toxicity with carfilzomib? And there is in about 7% of people. And so especially if someone has some underlying cardiac abnormalities, if they have heart disease, if they have uncontrolled high blood pressure, if they have something else that we've detected, whether it be on imaging, on echo, by symptoms, that makes us concerned that the heart is not completely normal, we do work that up before considering carfilzomib in someone.
Okay, great. Algorithms. This is an engineer question, it seems like. Do you give patients with any algorithms to a cure? Is MRD negative a good sign to help us know that these patients are cured? Kind of a double question there.
And I think the second one might be easier to kind of start with. I'd say MRD negativity is important. It means we're getting rid of as much of the myeloma, if not all of it, as we can. But what we don't have a good sense is the durability of that yet. So if we get to MRD negativity, does that mean cure? It seems as if there are a good majority of patients that are still going to relapse at some point. But what it does help us understand is first, we know that there are some patients who are going to have long-standing MRD negativity, and there are people who have what we would call functional cures. I'm not sure we're there yet to say that that's a majority of patients, however. But one of the exciting things about MRD negativity is the potential for stopping therapy. If we are getting people to our goal of getting rid of all the myeloma, do they still need to stay on therapy indefinitely? And this is the subject of a couple of different trials that are out there right now to say, if that is our goal, can we stop therapy and see what happens and get a sense of who is going to relapse and what time and in what timeline. So I would say the algorithm is personalized. So there is nothing that we can routinely give to say this is the plan, but we do think we know the goal or the end point of said plan.
Okay, that's great. Secondary cancers appearing in patients with multiple years of treatment. This person has gone through several things, but just finished radiation after lumpectomy for early breast cancer. Have you heard relationships with the myeloma treatment and breast cancer?
Sure. For better or for worse, the great irony of cancer treatments, and this is the case with, many cancer treatments, is that unfortunately they can sometimes cause cancer. It's hard to know if breast cancer, particularly extremely common cancer, is definitely associated with a multiple myeloma treatment, or if it was just kind of, let's say, happened at the same time coincidentally. We do know, however, that patients who, for example, get a transplant and are on Revlimid maintenance after a transplant do have a slightly higher risk of having a secondary cancer. And it can be of any type. We call them solid tumors, which are cancers of organs, or we can have cancers of other blood, such as leukemias, for example. This is the way I kind of try and help my patients understand it, is to say, yes, I know that there's a cancer risk for you. I would measure it on single-digit percent to say somewhere about 3 to 7% of patients can have a second cancer. I know that there's 100% chance, more than not, that your myeloma will come back. So if I'm measuring 100% chance of your myeloma coming back with a very small chance of a secondary cancer, in my mind, taking the Revlimid maintenance makes sense and is all the more important, reason for you to do your routine screening, mammograms, colonoscopies, all those things. So as best as we can try and identify those cancers should they occur.
This person started out with MGUS, then smoldering, but it's been 3 years since I've had, or they had their PET CT scan, and a bone marrow biopsy. What do you think they ought to do? Is it time to go back?
So I don't think that there's a specific timeline to say that every year you must get a biopsy or a PET scan. What I like to do is I track their blood tests to get a sense of a trajectory of change of their M spike as the most common example. If you see that your M spike is rising kind of year over year and reaches, let's say, a point where you're saying, I can see that the trajectory is heading in the upward direction, that would prompt me to make an intervention. Because if something's changing, I need to make sure that we're not seeing any changes under the surface. For those people who kind of had a steady, stable, my M spike that has not changed over the course of many years, I personally don't routinely do bone marrow biopsies and PET scans unless I see something that worries me that it's changing.
Oh my goodness, a 75-year-old team wants to do a stem cell transplant. Why not CAR T?
Well, kudos to you, first and foremost, because if you're 75 and they're thinking about a transplant, you must be a pretty darn good 75-year-old. We do not have upper limits of age to say you're too old, but I mean, reality is you could be a 75-year-old and be in great shape, but your kidneys are still 75, for example, and we still know that we have lots of tools at our disposal to use that can, at the age of 75, potentially let you enjoy a good long remission and a good long life than a transplant would. To answer your specific question, however, CAR T is not approved at an early enough place at this point. So as it stands, the FDA has only allowed us to do CAR Ts on patients who have had 4 or more prior lines of therapy. So a transplant we usually do after patients have had 1 line of therapy. A CAR T right now we can't do. It's coming though. There's lots of excitement to say is, can we do a CAR T sooner than what we're currently doing it? And yes, that's coming.
That's fantastic. Okay, here is a question that is kind of basic but important. What's the difference between a plasmacytoma and multiple myeloma?
Great question. So a plasmacytoma is, in the most simplistic means, is a myeloma tumor. So it means that a handful of these bad guy myeloma cells have kind of coalesced together to find a tumor. And I like to think of this happening in kind of 2 broad varieties. One is that it happens in a bone, and one is it happens outside of a bone. And the way it can happen inside of a bone, sometimes I like to think of it just, again, simplistically, is it's kind of like mushrooming out of a bone. If you think about a tumor that kind of forms out of the bone marrow, and can form a plasmacytoma or a tumor of myeloma cells in the bone itself. Sometimes those myeloma cells, however, can get out of the bones and misbehave and find their way to different organs. And that's what we would call an extramedullary plasmacytoma, where a myeloma tumor forms outside of the bone or a bone marrow. It may form in any organ, you name it. You can find it in skin, you can find it in lungs, you can find it in livers. Extramedullary plasmacytomas in organs is usually a manifestation of later disease points, happens kind of later in the disease process, but can happen in theory for anybody. And the treatment of extramedullary plasmacytomas or bone plasmacytomas is as if it were myeloma. You would treat them all the same.
Okay, I think that's it for this segment. What we need to do here is thank our speaker, Caitlin Costello. She will be back here shortly. And what we're going to do right now, I'm giving a golf clap there. Thank you, not to make too much noise. And what we'll do right now is we're going to go into, is it a break, Megan? Is that correct? And we do this for about 10 minutes. We're going to, oh, thank you. We're going to have meditation. Now, this is something the IMF feels is very important. Get to where you're paying attention, because some of this is so overwhelming. So you got to calm the soul. You got to calm yourself a bit so you can hear what's going on, because we don't want you to walk away and go, oh my gosh, what happened? And I'm even more confused right now. And what do I do? We got to get you to the point you can listen. So let's take a break. Thanks, docs. And we'll have Donna Camatero come up later on today. And I appreciate everyone's time. Well, how was that meditation? I hope it was good. I did it a little bit. And sometimes before I was paying attention to meditate properly, I'd take a nap. And my wife would say, "What's that all about? You're supposed to just take 5 minutes." And I don't know how many of you out there have done this. How about that 20-minute cat nap that just straightens out your day? So add those kind of things to what's going on because you're already stressed out enough and we want to pull you out of that. Oh, it's with great pleasure that I get to introduce our next doctor. Dr. Kershaw has been part of multiple myeloma for quite some time and has come up with a lot of treatment protocol and things, just wonderful ways to help myeloma patients. She's out at the City of Hope Comprehensive Cancer Center that's in Duarte, California. And I was reminded about the freeways out there, so make sure you put on your ways before you go there. Rita, you want to take over right now for relapse therapy and clinical trials?
Sure, Kelly. The one problem I have is I can't get the slides into full screen. So
Okay, Megan?
If you pin them, you should be able to pin the Studio A. Or I can try and spotlight it.
Now I got it. Excellent. All right. Thank you. All right. So,
Sorry.
then it goes away. Hold on, let me try again. Yeah, that doesn't work when you do it that way. Whatever you did before worked perfectly.
Can you pin the slides? If you tap the ellipsis at the top corner of the Studio A screen, there should be a pin option.
It doesn't give me that. That's the problem. I'm on an iPad. I don't know if that's why too. Oh, here, I found it. But it took a while. All right, got it. All right. All right, we will give it a try here. I guess we're all having our own technical. So thank you, Kelly, for the introduction, and thank you to everyone. So I'm sure some of you are familiar with our center. We've actually, we should also change that now. It's the City of Hope Cancer Center, Duarte, and we will be opening later this year in Irvine, California, which we're incredibly excited about. That will be a freestanding cancer center as well, where we will be doing autologous transplant, CAR T cells, clinical trials. So it's really an exciting year for us. So I'm going to talk, I don't have pictures yet of the Orange County facility, but we will be adding those. We're having a grand opening and yeah, it's on an iPad, but as you know, the camera's on the corner, so it's really awkward that way to do it. So here. Sorry, I love. So as I was saying, we're going to be opening in Orange County, and that will be an outpatient cancer center, and we are in the process of also building an inpatient hospital attached to that. So it's very exciting for us, as many of you have been traveling quite a distance to come to the campus in Duarte. So hopefully that will make things very helpful for patients in Orange County and South County. And so now, when you think about relapsed myeloma, it's pretty complicated. You know, Dr. Costello talked about newly diagnosed disease, showed you a timeline of all the drugs that we have developed that we've used in relapsed disease, and how do you pick? But in reality, you know, this is a picture taken, one of my colleagues, actually Dr. Chari gave me this slide. This was done during the peak of the pandemic, you know, making the point, oh, the beach looks really crowded. But actually, if you take another view of that beach, it's actually not that crowded. Now, that's a different view. Now let's go to a different camera view of the same beach. and some of you who live in Orange County may remember this from the OC Register, that's an aerial view of the beach. So you can see it's the same beach, different view, very different. And that's kind of the way it is with myeloma therapy, that you look like you have a ton of drugs, but in fact, as you get further and further along, those options become more narrow and really individualized to each person, depending on what they've had before, depending on the side effects they've had from prior chemotherapy, and depending on what's available in your area as well. So, and I put in here just some of the treatments you're very familiar with in terms of the main backbones of our therapy: proteasome inhibitors that Dr. Costello talked about, carfilzomib, bortezomib, ixazomib, then IMiDs, pomalidomide and lenalidomide, and then the anti-CD38 antibodies, isatuximab and daratumumab. We also have a CS1 antibody, elotuzumab, though at least for our center, it's not one that we particularly use a lot. We've had other drugs approved, such as selinexor, that was approved first for advanced disease, then for later relapses, earlier relapses. Again, not one that I particularly use a lot, but I know Dr. Chari and the group at Mount Sinai do use it more, and he was the lead author of the New England Journal paper about it. We have some that got taken away. Melflufen, I was never particularly a fan of that. And indeed, it was taken off the market in the US. Belantamab, a BCMA drug conjugate that I'm going to talk about, that is the first antibody drug conjugate approved in myeloma, and also the first BCMA targeting drug we had in myeloma. And the things that obviously everyone's incredibly excited about, the CAR T cells. We have 2 approved in myeloma. Idacaptogene, Biclocel, and Ciltacaptogene, Autoleucel. And we have both of those at City of Hope, and we'll talk about data with that, but also some of the challenges with that. So as I said, when you start out in that first line of therapy, it's like the crowded beach in Newport. You have a ton of people, ton of options. As you keep going, though, things narrow down, and that's really where it becomes a discussion with your physician and ideally with a myeloma specialist, given the nuances of these therapies. But the general principles, the first principle is that we, even in the relapse setting, aside from CAR T cells and aside from the bispecifics, what I'm going to be talking about, we prefer to use triplet therapy. We've had multiple studies suggesting that triplet therapy gives you better progression-free survival or longer remissions than using doublet therapy. And the biggest go-to regimen for us in the first relapse setting has really been an anti-CD38 backbone. And since we did the original studies with daratumumab, we've tended to use daratumumab or Darzalex as our backbone. And I show you here the Pollock study, which is been our go-to regimen of Darzalex plus lenalidomide plus dexamethasone in patients with early relapse disease. Now, the issue is, though, these patients cannot be refractory to lenalidomide. So, it does already eliminate a certain group of people who've progressed on lenalidomide, for example. The other thing to know in this study, when Pollux came out, it was given IV Darzalex, and that's obviously how we did it for a long time. But now the majority of our patients are getting subcutaneous Darzalex because obviously much quicker, much lower incidence of infusion reactions. Now, this is the challenge and sort of what I alluded to then as that beach gets less and less crowded is all the major phase 3. So phase 3 are randomized studies where you assign patients to 2 arms. Most of them assign one group of patients to lenalidomide and dexamethasone, and the other group was the experimental arm, meaning what the newer drug that we were studying, and that could be carfilzomib, elotuzumab, or in this case, daratumumab. And not surprisingly, this is where our idea of 3 drugs versus 2 came. If you give 3, you had better response rates between 80 to 90% and better lengths of remission. Here you can see remissions up to 2 years, depending on which regimen you choose. But if one of the arms of the trial is lenalidomide and dex, that means that you have to have a group of patients who will respond to that. And this is the challenge in myeloma in the US. most patients, especially those after stem cell transplant, are on lenalidomide maintenance. And Dr. Costello showed you that trial, the determination study, where indeed patients received len maintenance until it stopped working and the disease started to progress. So you can't really apply these trials to patients who are refractory to lenalidomide. So what do you do? The other challenge is I showed you that carfilzomib, I showed you daratumumab. We actually are using those earlier and earlier in the course of therapy. Sometimes now for newly diagnosed patients, very commonly we will give daratumumab, and sometimes we will give carfilzomib Lendex for newly diagnosed patients. So once you relapse after those, what are your options? And especially the challenge for us now is patients who relapse after an anti-CD38 antibody. Now, fortunately, CD38 is not the only target on the myeloma cell. And a big part of what we do at City of Hope has really been in terms of antibody-based therapies. We were the ones who developed rituximab, so we've always had an interest in antibodies, growing our own antibodies, and understanding and finding new targets. And so myeloma is ripe for new targets. And in fact, what I'm going to share with you some of the data of these targets. So GPRC5D, which is expressed on myeloma cells. It's also expressed on keratinized tissue. That means nail beds, hair follicles. FcRH5, which is expressed on B cells, so the cells that help make immunoglobulins, it's also expressed on myeloma cells. So those are the two biggest targets, and BCMA, obviously, that we will be talking about in the context of CAR T cells and in the context of bispecific antibodies. So I'd say BCMA is probably the biggest thing right now in myeloma. The other targets are somewhat less well developed, but getting there. So let's talk about bispecific antibodies, which is what I was really tasked with today, because to give you sort of the latest and greatest thing that we're very excited about. So first of all, antibodies, right? So Dr. Costello told you that myeloma is a disease where you make antibodies, but we also ironically use antibodies to treat myeloma, and there can be different types. So we have naked antibodies, so that is daratumumab. It's a naked antibody that binds to CD38, the same with isatuximab. You can have an antibody where you attach something to it. We call it a warhead, for example. In this case, on the left, you see antibody drug conjugate with the chemotherapy attached to it, such as belantamab. And the reason you do that is because, for example, if I gave you just the chemotherapy, in the case of belantamab, it's called belantamab mafodotin, it would be incredibly toxic. It causes a lot of liver toxicity. But if I attach it to an antibody, and that antibody will only go attach to myeloma cells and then release the chemotherapy into the myeloma cell, hopefully the toxicity will only kill the myeloma cell, but you won't get a lot of toxicity to other organs in the body. And that's kind of the premise behind antibody drug conjugates. We're actually doing some exciting clinical trials, and one that we're going to open later this year, using antibodies labeled to radioimmunotherapy. So using sort of in a way a very targeted radioactive antibody that we're very excited about. That may be another option for patients with relapsed myeloma. The next thing that we look at is bispecifics and trispecifics, and we have both of those on clinical trials at City of Hope as well. Just first, let's look at the bispecific. So what the bispecific does is it's called bi because it has two attachments. In this case, one attachment is to the myeloma antigen. That can be BCMA, which we'll look at. It can be the others I talked to you about, GPRC5D, FcRH5, and many more in the pipeline. The other attachment is to the T cells, so the immune cells in your body. And so in a way, if you think about CAR T, you take out your T cells, you engineer them against BCMA and put them back. Bispecifics, you give someone an antibody that activates the T cells in their own body. And then trispecifics, kind of the same concept as a bispecific, but they add a third binding to try and make those T cells even more active. And so, again, multiple different ways to activate the immune system to fight myeloma. So now let's talk about the trial results that we have and why are we so excited. Well, let's start with just the naked antibody first. First and foremost, well known. So I told you that the challenge we have is most people are refractory to lenalidomide by the time they get into that early relapse. So what do you do? So one of the questions is, do you change classes of drugs or can you stay in the same class? And we often stay in the same class and just switch to pomalidomide. And if patients have not had daratumumab or haven't seen daratumumab for a long time, for example, if someone has had daratumumab for their initial therapy, then they had a stem cell transplant, and then we're on lenalidomide maintenance. If the myeloma comes back, it's very reasonable to restart daratumumab and then switch out that lenalidomide, and often we use pomalidomide. And you can see here, this is based on the Apollo study. POM is very similar to Len in the terms of the schedule. Now, in the Apollo study, it was given as 4 milligrams. I actually don't do that at 4, and I'd be interested to see what Dr. Costello says as well. It tends to be very hard on the blood counts to give it at 4, and really the effectiveness is about the same when you give it at 2. So we usually use 2 milligrams. With the Darzalex in combination, and then the steroids, obviously. And again, some of the steroids too, we tend to adjust as needed, because you could 40 milligrams is a challenging dose for a lot of patients, and often we cut that down to 20 milligrams based on side effects as well. And you can see here, when you gave Darzalex plus pomalidomide and Dex, you got remissions of progression-free survival, which is about a year. So not a home run, but as Dr. Costello said, myeloma therapy is a marathon. So you start, that's one leg of that race. Now we have another regimen you could argue that is even possibly more active, and this is what I tend to use in people who have more aggressive relapses, people who are younger, people who are a little bit also willing to come in to get carfilzomib on this schedule, because that is the one issue with this is you have to come in and get IV carfilzomib. But this is the Candor study, also for people who had early relapse disease, getting carfilzomib plus daratumumab plus dexamethasone. And when this trial was done, it was initially done with IV daratumumab, though we have now supplanted that and used daratumumab as an injection. And I think that the reason that we use this is, to my mind, this is probably one of the most effective CD38 combinations. So with, because you can see here, if you look at these curves in regards to how long people stay in remission, that curve doesn't drop off. It's pretty impressive that over 50% of people are still in remission at 2 years. So again, that's the good news. It's an effective, potent regimen. Many of you are familiar with the side effects of carfilzomib, but not always the easiest drug to give. And so you can see that in terms of blood count, but more concerning, and this is why I worry more in older patients, of the infection risks. And especially in people over the age of 65, we saw pneumonia, sepsis. So really close attention to infectious prevention is really needed when you use this regimen. So I do use this regimen, but I do use it with caution and select carefully who I'm going to give this regimen to. Of course, daratumumab, as I said, is not the only anti-CD38 antibody, and we have isatuximab as well. And this is a similar trial using ISA plus KD, same kind of idea. ISA, just to remind those of you, is given a little differently than daratumumab. It's on an every 2-week, and it is an IV drug. And then the carfilzomib is the same. And you, again, saw that same similar thing that looks like a lot of people, that red line there. At the top, it shows that people who are staying in remission. So it looks very promising as a potent combination that gets you fairly long remissions in relapsed myeloma. You could also use isatuximab with pomalidomide. So I showed you the Apollo study, daratumumab plus pomalidomide. Here we have isatuximab plus pomalidomide. And it's really, don't get into the weeds about the details of the study. It's more the idea that if your doctor says, I want to give you isatuximab, and you say, no, I want dara, it's less of that, just to understand it's the combination of a CD38 antibody plus another drug, and is really what we're showing as a very effective drug. There's some other regimens in myeloma, is like cooking, right? It's very, you mix and match in different recipes, and this is one that was developed, and Dr. Richardson published on this. I actually don't use this a lot. A small number of patients, people, for example, who want a little bit more user-friendly schedule, maybe people who, for whatever reason, can't take an anti-CD38 antibody, or maybe you've already had it, and then the myeloma starts to come back. These, again, that beach now is becoming less and less crowded because you've now eliminated a bunch of drugs. So by the time I get to this regimen, it means that people have a variety of reasons, can't get a CD38 antibody, can't get carfilzomib, can't get, and so I'm, it's not a regimen I use a lot, but I use it maybe in older people, for example, people who had a lot of side effects from other drugs, and it's pomalidomide plus bortezomib plus dexamethasone. And this is sort of tells you why myeloma is hard. It's just trying to pick and individualize a therapy. Now, my slide advancer is no longer, there we go. And just to show you here the flavor of that, but this is Dr. Richardson's paper. And you can see, if you remember, I showed you those curves with the Darzalex, and this curve's much less. I told you with the isatuximab, carfilzomib, over 50% of people are in remission at 2 years. Here, if you look at 2 years, it's much less. You see about 10% of people. So just to give you a sense in terms of potency and activity, though obviously it's hard to compare, it's a different group of patients. So, but just expectations when you use a different regimen are somewhat different. Sorry, my slide advancer is taking its own mind. Here we go. So now let's switch gears. So we move beyond anti-CD38 antibodies and talk about that BCMA targeting. So belantamab mafodotin. So BCMA directed, BCMA is highly expressed on myeloma cells. We have that warhead attached to it, the MMAF, or mafodotin. So you can see here in this cartoon, what happens is the antibody attaches to the myeloma cell. That chemotherapy is internalized into the myeloma cell and kills the myeloma cell. This drug also activates the immune system, and that's what they mean when they say effector cell. So that's the good news. And this study drug was approved by the FDA on what we call an accelerated approval, meaning they identified that this was truly an unmet need for patients. And it was on the DREAM2 study, where they looked at belantamab at 2 different doses. And the reason it got such a quick approval is patients had really unmet needs. And you can see here, patients had a median of 7 prior lines of therapy. So when belantamab came around, there was not many good options for patients who had relapsed that much. 100% had been refractory now to proteasome inhibitors, to immunomodulatory drugs, and to anti-CD38 antibodies. So you can imagine when belantamab was on, what do you do after that? So there was getting a response rate in about a third of patients. 31% was very exciting. And so it really does have a platform and use for patients who have advanced disease. It's approved after 4 prior lines of therapy. The challenge is on the bottom when we talk about keratopathy. So the ocular toxicity of belantamab is where we really have a challenge and managing that. So belantamab requires that everyone have an eye exam before you start and before each dose. And my experience, the majority of patients end up with dose holds and dose reductions because of the eye toxicity. Now, that doesn't mean to say you don't use this drug, but it really means to say we're still learning how to optimally use that drug. And so some of the questions that come out, I show you the Dream 4, Dream 5, it actually goes up to Dream 9, which I didn't include, is combining it with other drugs. So maybe you need to give the belantamab less frequently. Right now it's given on an every 3-week schedule. Maybe if you gave it every 4 weeks or 6 weeks, you could get less eye toxicity. Maybe if you give it with other drugs, you can reduce some of that toxicity. Those are the things that we're trying to learn as we look at these combination studies. And indeed, most of us think that belantamab is not going to be used just by itself, because the response rate of 30% when it came out, we were excited about. But now when I show you CAR T and bispecifics, we can say that 30% is no longer enough for us, given the other options. And indeed, when you look at it in combination with other things here with earlier in the disease, 3 prior lines of therapy, so not as far relapse, and combining it with bortezomib, 78% of patients responded. So, we will see. Now, it's interesting. There was another antibody drug conjugate that we don't have experience with. It was the Mayo Clinic had been doing the study, MEDI228. And interestingly, you see, again, very advanced group of patients, up to 11 prior lines of therapy. And you could see that while people didn't get keratopathy, which is corneal toxicity, patients did get photophobia, so light bothering their eyes, dry eyes. And interestingly, about 1/5 of the patients developed pleural effusions, or basically fluid in their lungs. So we do see that there are other what we call off-targets, so effects beyond the myeloma cell when we use these antibody drug conjugates, that we're still learning about how to optimize the responses but minimize the toxicities with these drugs. And so I think they do have a space in patients who have more advanced myeloma. They are actually being studied earlier in the course of the disease, even including in newly diagnosed patients with belantamab. My personal opinion, that is a harder sell because of some of these toxicity profiles, given the other options in newly diagnosed patients. But certainly in the relapsed myeloma space, I think these are certainly drugs that we use in different combinations. Now let's turn now to the thing that everyone is, really kind of the biggest buzz in the block, and that is CAR T cells. And let me see if I can get this to advance. Here we go. So we have 2. First came along Abecma or ide-cel, March of 2021, the first gene therapy for multiple myeloma. Then almost about a year later, we got the second, Carvykti. And you could argue, why do you need 2? Well, because when I tell you some of the challenges of CAR T cells, I'm glad we have 2. I wish we had more. So these were the first not targeting CD19. So the lymphoma people are lucky. They have so many CAR T cell options for targeting CD19, which is the target on lymphoma. But we did not have anything for myeloma in terms of CAR T until these 2 came along. They target our old friend BCMA. So here are the 2, and just to show you what they are, we actually had a third one that we were doing at City of Hope that ultimately never got put forward further, called JCAR. So we had cilta-cel and ide-cel, sort of the nicknames for them. You can just see these cartoons here. They target BCMA. They're engineered a little bit differently. That's really all this shows you in terms of how they're made. So this is the study that led to ide-cel first. So again, relapsed advanced myeloma, usual blood counts, etc. Patients got their T cells collected. And then you can see here, it says bridging chemotherapy. And the reason for that is, as you can imagine, it takes time to engineer and make those T cells. So in the trials, it was about 3 to 4 weeks. In the real world, it's actually being more about 5 to 6 weeks. So if you have very advanced myeloma, as you can imagine, it's hard to wait 5 weeks without treatment before you get your CAR T cells. So patients often needed some kind of chemotherapy to try and hold their disease, keep that pot from boiling while the CAR T cells were being made. And that's also easier said than done, because you can imagine by the time you get to CAR T cells, myeloma has been pretty hard to treat. So trying to find something that will hold things steady, it takes sometimes a lot of sort of heads put together to come up with that. And it's not one size fits all there at all. It's really very individualized at that point. Now, why were we so excited about this drug? Because you can see here when we look at the response rates, and don't get fooled by when you compare ide-cel to cilta-cel, they say, oh, the response rates. So remember, these studies, when we were learning, we started at low doses of the cells and slowly increased the doses. So it was, by the time we got to the doses that were active, really the response rate was over 90%. And that's kind of the take-home message. And not just responding, people going into remission. And that was incredible. When we saw how many previous treatments and how many things people had been exposed to. So that's the great news. The challenges we still have are it's not a cure. So you can see here, we say median PFS, so progression-free, or how long patients could, basically their responses were maintained, was about a year. People who got into remission with it, it was longer, but still not a cure. So now there are lots of studies and things that we're doing to try and improve upon this. And you could argue it's a catch-22. The nice thing for patients who've had CAR T cells, they've always said, it's one and done. It's the first time in that myeloma marathon where I haven't needed any other continuous therapy. But in fact, now we are looking at what we call maintenance therapy after CAR T cells as well, to try and improve upon that number of 12 months. Now, when we look at side effects, that's where we get into some of the unique things. But first, let me just show you the longer-term follow-up, just in terms of here. And the question I often get, we had a patient who was someone in the questions who was 75 asking about CAR T as well, and you can see that toxicity and survival seems over 65, under 65 to be similar. There may be a little bit more in terms of things that we worry about in terms of neurologic toxicity and this phenomenon known as cytokine release that I'll get into. But certainly it is age per se is not a specific contraindication to it. Now let's look at, try and let the slide advancers. Here we go. Now, cilta-cel is the other one. Again, advanced disease, 3 or more prior lines of therapy. The patients that had that same PI, IMID, CD38 antibody, response rate 98%. Incredibly exciting for us. Again, don't want to compare apples to oranges, but you can see here that 2 years, over 50%, so actually 60% of people were still in a remission. So very exciting. People who'd had 6 prior lines of therapy, so very advanced myeloma, responding to treatment and staying in remission. So those are the great news of all the CAR Ts. Here are the challenges. Cytokine release. So what is that? Well, everyone's heard about cytokines, and you talk about COVID, for example. Why do you get fever? Low oxygen, things like that. So those are the things you can see with cytokine release. Cytokines are basically proteins released in the body in response to an infection, in response to an inflammation. They are inflammatory proteins, so they will cause you to get a fever. They'll cause you to get low oxygen, low blood pressure. And because of that, we have to monitor patients very closely after CAR T cells. And you can see most people get cytokine release after CAR T, 95% of them, in fact. And that's expected. What we just don't want is patients to get it severely. And that's grade 3. So grade 1, grade 2, we expect and we manage. You can see also a little bit different. It's interesting. With ide-cel, cytokine release tends to occur within 2 days. Cilta-cel, it occurs a week later. So it doesn't mean, so you have to be aware of that when you give the CAR T. It doesn't mean if you give cilta-cel, oh, you're 2 days later, you're fine. Okay, don't worry. No, it's just a different onset for when that happens. And we think that's related to the cells growing in the patient's body, and how quick when they expand is when you see the cytokine release. The other thing you can see is neurologic toxicity. So ICANS is the fancy way of saying we call it, but it's immune effector cell neurologic symptoms. And those can be mild. It can be a headache. It can be a tremor. It can be a little bit more severe. It can be word finding difficulties. It can be, in the worst cases, which we don't want, it could be patients becoming completely unresponsive, patients having seizures, patients having elevated what we call intracranial pressure, so evidence of swelling in the brain. So again, we don't want to see those severe side effects. And so what we try and do is, one, get patients in the best shape before the CAR T to reduce those risks. And that means that's part of that bridging chemotherapy, trying to reduce the myeloma as much as we can, because we know that people have a lot of myeloma are more at risk for cytokine release, more at risk for the neurologic toxicity especially. And then obviously we do have drugs to treat it. So Toci was a big challenge because we use it for COVID too. So there was a huge national shortage of Toci during the peak of the pandemic. We used a lot of steroids as well for the neurologic toxicity. And let me just move on here. Here we go. So this is the biggest thing. So CAR T cells, incredibly exciting. Response rates, as I said, 90–95% of patients. But can you get a CAR T cell? And this was Dr. Yi Lin from Mayo Clinic surveyed and presented this data of serving a bunch of CAR T cell centers. I don't know if Dr. Costello participated in this survey too, but basically what it said is most centers, we don't get a lot of spots. We get, you can see number of spots centers are given 0 to 4 per month. How many do you have on your wait list? Some centers have up to 100 patients on their wait list for these. So, it's a challenge. So, we think they work, but we don't have enough. And so getting patients access to these therapies remains a huge struggle for us. So let me see. So those are kind of now, so a little bit ironic. So I'm telling you that we huge struggles of getting access. We have only a few CAR T spots, but at the same time, we're also trying to use CAR T cells earlier and earlier in the course of disease. And you can see here, including in newly diagnosed myeloma, we have some trials going on, trying to say maybe if you have really high-risk myeloma, maybe CAR T would be a better option for you. And the rationale behind that is your T cells are fitter earlier in the race. So it's kind of like, the Boston Marathon, right? Before you get to Heartbreak Hill, your legs are in better shape. So same with your T cells. So if you use it maybe when you're newly diagnosed, you can get even longer remissions. And so that's some of the trials that we're looking at right now. So there's lots of unanswered questions with CAR T cells. As a cellular therapy center, I'm a huge believer, incredibly excited. I showed you data in older patients that there doesn't seem to be differences in outcomes. So is there an upper age limit? Probably not. What we don't know is, myeloma patients tend to have kidney problems. All those trials excluded people who had really bad kidneys, but can you do it in people with bad kidneys? Because that's the real world. What about people who have myeloma in their brain? Again, those trials excluded them. Can you do it and not get too much neurologic toxicity? What about people who are a little bit more frail? Are there ways maybe you give a different cell dose, or you give steroids, or different ways to allow you to do it for more patients is really what we're looking for. Plasma cell leukemia, one of the most aggressive types of myeloma we have, all those trials excluded it. But so again, patients who really need it, Can we do it? So these are our unanswered questions. Now, so I told you CAR T cells, very exciting. BCMA targeting, just getting access to them, challenging. So why, and that is in part why we're so excited about the bispecific antibodies, is because they're off the shelf. You can, and so you have another way of activating T cells. And here you can see, so we target the myeloma cell and the T cell and bring that T cell closer to the myeloma cell to kill it. The one that's the furthest along is teclistamab, that it's been presented several times, published in the New England Journal now, and it targets BCMA and CD3, which is on the T cell. It's given, it was initially studied both IV and subcutaneous, and obviously the form going ahead has been the subcutaneous. And I'm going to show you some of the results of this study. So first of all, same thing. Anytime you activate T cells, you get cytokine release. You see it here. So with CAR T, you see it with bispecifics. 80% of people getting cytokine release, usually very mild, fortunately. Responses. So again, median of 6 prior regimens. So people in the study had a lot of different therapies. About 70% of them responded. So very exciting for us. And people even went into remission. So again, an off-the-shelf option. Now, the challenge with this drug, though, is because of that cytokine release in 80% of people, we give the first doses in the hospital. We call it priming doses, and we give 2 little doses. So people in the hospital for about 4 or 5 days to monitor and treat that cytokine release before they can be switched to the outpatient setting. So that makes it a little bit less user-friendly. And we still need to learn and figure out how are we going to be able to do this as an outpatient to really get this for more people. The other question with this bispecifics is how long do those responses last? Well, it seems like on this slide here, you can see that responses are going on for over a year, and people's responses seem to get deeper and deeper. I can tell you, I have a patient who's on it now for almost 3 years. So, again, very exciting for us. Not only do people respond, but they continue to respond for a long time. Things you need to worry about: infection. So this is a summary of all the bispecifics. So you can see now many companies have jumped into this race, and I'm not going to go into all the details, but just tell you that all the big players are there. You can see they all seem to have similar response rates, about 60 to 70% of people responding. Hard to know if any one of them has responses that last longer because we don't really compare them to each other. But the biggest thing, they all cause cytokine release, infection. So I can tell you with teclistamab, for example, of the deaths, there were 12 deaths due to COVID infection. So it's been particularly challenging for us during this pandemic, but we also see other infections that we never used to see except in allogeneic transplant, those unique kind of viral infections such as CMV infection, for example. So, we're learning as more and more time goes on how to better prevent infections in patients on these therapies to try and make them safer. And as this drug gets approved, and teclistamab is probably going to get approved later this year, like that, we really need to not only be able to offer it to more people, but we need to be able to do that in a way that makes it as safe as possible. Now, I mentioned to you earlier, there are other targets. So this one's a little bit further behind, but not that far behind, and probably maybe by early next year get approved. Talquetamab, targeting GPRC, which I said was expressed on keratinized tissue, so nail beds and hair follicles. Same idea, attaches to the T cell and to the myeloma cell. Same kind of response rates, about 70% of people responding. Very exciting. Again, people that had 6 prior regimens, 83% of them had been refractory, penta-refractory, meaning failing 2 proteasome inhibitors, 2 IMiDs, and a CD38 antibody. So really people who had not too many other options left. Same concept here too, exciting that these responses seem to be going on for a long time. And unique toxicities though, certainly cytokine release, nail toxicity. So some people even lost their fingernails. They do grow back, but that's a challenge. Dysgeusia, fancy way of saying loss of taste. 60% of people have had dysgeusia with this drug. And as you can imagine, that really affects your quality of life. And so we're still learning in terms of dose and schedule how to optimally be able to reduce the side effects, but continue to, have people respond to that treatment. Another one we have is cevostamab, or different target, FcRH5 on B cells and myeloma cells. Same idea, target the myeloma cell, target the T cell. Same idea of all of them, step-up dosing, or they call it different things. Some people call it step-up dose, some people call it priming dose. It basically means tiny doses so that the cytokine release isn't too severe, and then you give the real dose that works. And so you can see here, we're studying many different schedules. It's very confusing. We have 3 step-up dose schedule, 2 step-up dose, different step-up doses, because we're still trying to figure this out. But basically, bottom line is heavily pretreated patients, again, 6 prior lines of therapy, cytokine release again. So now you guys will all be cytokine release experts in 80% of patients. Responses in about 60% of patients that also seem to get deeper and over time. And so again, another exciting option for us. I can tell you I've had patients on this trial who had relapsed after CAR T cells who've had remarkable responses to this. So it's nice for us to know that we have a lot of new options for our patients. So this is kind of a summary. And, you're going to see in many of the myeloma meetings, always these debates now between the CAR T people and the bispecific, which is better. I don't think of it that way. I think that as Dr. Costello said, myeloma is a marathon. People are going to be getting all these therapies at some point in their treatment. And it's just really individualizing that for each patient of when is that therapy the best option for them. But we're really excited. We have CAR T cells, incredible response rate. Basically, most people respond, but manufacturing time's a challenge. In the real world, it's 5 to 6 weeks. You have to go to a CAR T center. You have to have your CAR T cells collected, so your disease has to kind of stay in check while you're waiting for those cells to manufacture. After the CAR T therapy, people can have low blood counts up to 6 months. You can have, I told you, early neurologic toxicity, but we also can see delayed neurologic toxicity or Parkinsonian. So like a delayed Parkinson's type thing in about 5% of patients. And that is something more common in older patients. So something that we worry about. Infection, very much so. CAR T is a great option, but it is not without its also limitations and challenges. Bispecifics, we like them a lot because they give you the option of off the shelf. I can just order it, pharmacy gets it. But again, we still need to figure out how to give it as an outpatient in the community, because right now we're giving that first couple doses inpatient because of the cytokine release. We're still learning the dose and schedule of many of these drugs. The other thing is they're not a one and done, so patients are still getting them every 2 weeks for 3 years, for example. Do we really need to do that? Can we give them just a shorter course of therapy? We're still learning, because infection is a big concern of keeping people on these treatments. And then the antibody drug conjugates, the response rates appear lower, but they don't have cytokine release. They don't have the neurologic toxicity. They do have the ocular toxicity, but maybe as we get better in terms of dose and schedule, we can kind of reduce that risk as well. So let me see, I think that may be my last slide. Yep, so basically we are excited. We have these new targets, we have these new drugs, which soon are going to be FDA approved. And we have CAR T cells, which are going to probably be used earlier and earlier in the course of myeloma therapy. And hopefully we can improve access to them as well. And I will stop there.
Oh my goodness. That was a lot of information. Thank you so much. Oh, we've got some good questions. Let's see. Is there or will there be a way to determine which bispecific would work best for a specific patient? Who would do the best with BCMA, or this one I've never seen, GPRC5D, and I've seen SLAM F7. So what do you think there? Is there a way to determine what one will work best for someone outside of the earlier treatment?
Not really. I mean, I think that's a great question. I think the thing we don't know is, for example, if you relapse after a BCMA CAR T, will you go straight to BCMA bispecific, or will you change to something else? I can tell you some of the bispecifics now are looking specifically at people who've had prior BCMA therapy, and you can still respond. So I think that's not just germane to bispecific, it's just the way myeloma therapy is. We don't have a perfect predictor of who's going to respond. I mean, as a plug, we have a grant at City of Hope that we got where we are collecting blood on patients before they get certain immune therapies and seeing if we can use their immune system to predict who's going to respond to what therapy. So right now, we don't know. Long story short.
Well, no, that was a great explanation. Another patient here, I've heard sub-Q daratumumab is always a standard dose as compared with IV daratumumab. Which is dose adjusted to patient? Do you think there is an advantage to remaining on IV daratumumab as opposed to sub-Q? Or sub-Q?
Well, I mean, the study that was done was called a non-inferiority study, where they looked exactly at IV versus sub-Q dosing, and the response rates were within the boundaries of basically not being significantly different. I think we don't have a specific subgroup. You're right, it is a flat dose. So for people who perhaps have a very high BMI, possibly could there be a difference? We don't have that data really. But generally, I personally don't see a huge difference. And for example, if someone's progressing on sub-Q daratumumab, I wouldn't change them to IV and expect to see any really substantive response difference.
Here's a tough question. What about the expense of CAR T, and have insurance coverage paying attention to it? I don't understand what they actually add, but it's the expense of CAR T.
No, it is a very expensive therapy. Obviously, you have to get insurance approval before you can go ahead with it. And insurers the thing they key in on is the number of prior lines of therapy. CAR T cells are approved after 4 or more prior lines of therapy. So that doesn't mean 4 or more drugs. It means lines of therapy. And that can be hard to kind of wrap your mind around. I'll give you an example. If you get RVD induction, you get an autologous transplant, followed by lenalidomide maintenance. That sounds like a lot of treatment, but that's actually only 1 line of therapy. Mm-hmm. So just to give you that sense, it's not how many chemo regimens you've had, but it's lines.
Well, that was a very good explanation of that. Patient here has a question. Are you generally giving proteasome inhibitors, Velcade or carfilzomib, once or twice per week? Is there a generality there that you can say?
It's not really a generality. I generally try to get things down to once a week just to make it easier for patients. I usually start with carfilzomib twice a week. If people are tolerating it okay, I'll go to once a week. But I've had some patients who just cannot tolerate the higher once a week dosing.
I see. Now, in your talk, did you discuss CAR-NK cells?
No. So just because we had limited time, we do have NK cells that are in trial. We actually are opening 2 studies at City of Hope using CAR-NK cells. So those are basically just different immune cells that are being used to target against myeloma. And maybe some lower cytokine release, for example, and some other benefits. The challenge with NK cells, they don't last as long in the body. So, you know, it balancing less side effects, but maybe the efficacy. So that's what we're working on.
And with that, all of us give a round of applause to Amrita for going through such a complicated topic. I want you all to know who's listening right now. If you did miss some of the concepts, slides, or discussions, we have it recorded at the IMF, and it will be up next week. And I think that will help you. You'll look at your notes and you'll go, oh, I get this more. So we're going to go into the lightning round, as it were, with Donna, who's on our Nurse Leadership Board. She has so many acronyms after her name. They just keep coming, and I don't know what they all mean. So let's just take it away, Donna, and do your thing. I appreciate you being here today.
Thank you, Kelly. So basically, what you saw all the exciting treatments that Drs. Costello and Krishna talked about, but with any treatment comes potential side effects. So we're going to talk about the more common side effects and how to best manage them. We'll also discuss how you can best frame your care through education and shared decision-making. And then finally, we'll discuss supportive care measures that can really optimize your healthcare outcomes. So with different symptoms that can affect your quality of life, we put them in 3 buckets. So physical symptoms, so that's fatigue, constipation, pain, and I'm seeing a lot of questions on neuropathy. Psychological, so depression, anxiety, insomnia, and then financial. Multiple myeloma is one of the most expensive diseases to treat. So one of the more common side effects are GI symptoms. So this is diarrhea and or constipation, and medications that we use that can cause diarrhea. That's, Revlimid, Pomalyst, Velcade, Expovio. They can all cause diarrhea. And then other supportive care medications that we use, like antibiotics, antidepressants. How do we best manage diarrhea? So we have great over-the-counter antidiarrheal medications, Imodium. That's not working, we can prescribe Lamodal. Fiber binding agents such as Metamucil and Benefiber can be very helpful. And for those patients who have chronic diarrhea who are on Revlimid maintenance, Welchol can be very, very helpful. Constipation can also be caused by Velcade and Revlimid and pain medication. So, how do we best support that? And also patients who are on iron supplements, vitamin B supplements can also cause constipation. So I recommend increasing the fiber in your diet. Just like we saw in diarrhea, those fiber binding agents can be very, very useful. We can also prescribe a bowel regimen, typically with a stool softener and a laxative, so Colace, Senecot, can help patients through. Regardless if patients have diarrhea or constipation, it's very, very important to maintain fluid intake. So I recommend 2 liters a day unless you were otherwise directed. And this is really preventing dehydration, and it's really protecting those kidneys that can often be affected by myeloma. So pain can significantly impact a patient's quality of life. And the majority of the pain typically comes from bone destruction caused by the myeloma. And so our goal is really to prevent any pathological fractures. So typically at the time of diagnosis, we will prescribe bone strengtheners. Zometa, Xgeva are typically the ones that we prescribe. It's also important to understand, where is the pain coming from? Is it something that we can radiate? Can we do a surgical intervention? So patients with compression fractures in the spine, kyphoplasty is a surgical intervention, which often helps patients with relief. And no patient should ever be a martyr. If you're having pain, talk to us. We can often prescribe a safe pain regimen, pain medication regimen for you. neuropathy. So I saw a lot of questions coming in the chat about neuropathy. Neuropathy is one of the most problematic symptoms that we have to manage, and symptoms include numbness, tingling, especially in your fingertips, hands, or feet. Sometimes it can actually cause pain. And peripheral neuropathy can be caused by some of the medications we give, Velcade, thalidomide, Revlimid, pomalidomide, all can cause neuropathy. Unfortunately, I do not have a silver bullet that I can give a patient to get rid of the symptoms. It's important to see, does the patient have any other issues that are causing the neuropathy? Is it diabetes? Maybe poor management of a patient's diabetes can cause neuropathy, or a deficiency, a vitamin deficiency. So sometimes vitamin B, if you are deficient, so adding these supplementations can help. Medications too can help. So we oftentimes will give gabapentin or Lyrica. This may be helpful, but again, it might not take away the symptoms. And then patients do find that alternative medicine, such as acupuncture or pressure, can be helpful. Yoga can be helpful. But it's very, very, very important that you tell your healthcare team that you're having these symptoms, because sometimes these symptoms can be permanent. So we want to make sure we avoid that. We can decrease your dose or decrease the schedule to help you better to mitigate these side effects. So fatigue, anxiety, depression. So you can see here on this slide that almost every patient will complain of fatigue, and that can be from anemia, low red blood counts, pain, sleep disturbances, anxiety and depression. Up to a third of patients report this, and I really think this is underreported. Patients sometimes do not feel comfortable talking about this with their team, but please do. We have services and support measures that we can help you through this difficult time. Financial burden. So I did earlier say that multiple myeloma is one of the most expensive diseases, chronic diseases to treat. The high costs, so patients may have high premiums, high copays, travel expense. I'm coming from New York City. Patients often have to pay tolls, and it's not uncommon for a patient to pay $50 a day for parking. Hopefully that's not the case where you're going. But there's a lot of cost just getting to your treatments. And then loss of income, time away from work to go to your treatment appointments. So it's important to let us know if you are having high copays. I did have a patient who was receiving Xgeva. It was costing her $300 extra a month. Once she let us know that, we could change that treatment to Zometa, which was covered 100% by her insurance. So let us know if you're having financial burden. There are resources, we can switch around things, and there's many websites you can see here on this slide that can help with, there are grants to give patients to help with their copay assistance, and work closely with your social worker to apply for these benefits. And then I would be remiss to say we are still in a global pandemic and we're still dealing with COVID-19. We have a new Omicron variant that is the most contagious variant to date. So we urge all our patients to get vaccinated and boosted. Hopefully we will have a new booster this fall that will cover the Omicron variant. And patients who are post-CAR T or are on BCMA-directed therapies are at higher risk for severe complications for COVID-19. And I say the best way of prevention is wearing a mask. I know a lot of mandates have dropped, but just assess the situation. Wearing a mask really can prevent infection. Also be informed, know what your antibody level is. About a third of patients don't amount any response to the COVID vaccines. We do have prophylactic treatment we can give patients, Evusheld. So for our patients who've amounted no response to the vaccine or who are on BCMA targeted therapies, we recommend this to give them some protection against COVID-19. So again, just to recap, how does COVID spread? Is through respiratory droplets. So if I'm talking to someone and I am infected, I am spreading that disease to them, especially if they are not have a physical barrier such as a mask. and we talk about masks. So there's different types of masks. So a cloth mask is better than no mask. A surgical mask is better than a cloth mask. But what we really recommend are high quality masks. So those N95, KN95s, and now they are readily available in pharmacies, and even on Amazon, you can pick up high quality masks. And then this slide just shows how effective mask wearing is. So if I'm infected and I'm speaking to someone who is not wearing a mask, I can infect them. And this slide says under 15 minutes, but we know with these new variants, it's much, much quicker than that. But you can see if we're both wearing N95 masks, we have over a day of protection. So I recommend these high quality masks, especially if you're flying or in crowded situations. And this even goes for outdoor events, as we're seeing it's such a high spread in a lot of communities. And just having the diagnosis of myeloma, you have an immune dysfunction. And we see that up to 10-fold increase of myeloma patients have infections. And we talked about patients who have with CAR T and these BCMA-directed therapy that even increases their risk even more. So you are at higher risk for infections. So just healthy strategies to begin with. So, be active, rest when you need to rest, maintain a healthy diet. Patients will often ask if there's a specific food or diet they need to, like a food that they need to avoid or what kind of diet. I say a normal healthy diet, anything in moderation. So don't deprive yourself, but just be mindful. And keep active. So don't overdo it, but one of the best interventions to help with fatigue is to actually get up and take a walk, and that can really help you, but know when you need to rest. And, with this pandemic, the majority of Americans did have some type of weight gain. So again, I do want to stress, be active, healthy diet, and get regular sleep. So come to your visits prepared. Always bring a list of medications, and that's also over the counter and any supplements that you are on. Write down your questions and prioritize them. Sometimes we can't address all questions, but we want to address the most important questions to you. Let us know if there's been any medical changes since the last time we've seen you. Write down all your symptoms. Tell us all your symptoms. They might be minor to you, but maybe important to us to know. In this day and age with COVID, telemedicine has been very popular with my patients. If you are doing telemedicine, make sure you have the appropriate technology, plan ahead, do your labs a week before so that we can have an informed visit. And then if you can, collect your vital signs. So with these smartwatches, we can get our pulse, take your blood pressure, take your temperature. And then be part of the decision. So you are the central part of the healthcare team. Make sure that you are part of the conversation. Let us know what your priorities and goals are, and we can really shape that treatment plan around your goals. And there are so many resources available through the IMF for you. We have downloadable pamphlets. All these resources available are on our website, myeloma.org. And then just a word about clinical trials. Dr. Costello and Dr. Krishna talked about these exciting treatment options, but they all came from clinical trials. So if you are presented with a clinical trial, please consider taking part of a clinical trial. But not all clinical trials are the same. There are different phases. So just briefly, a phase 1 trial is the first time we're using a drug in humans. We're trying to figure out the right dose, and we're trying to identify all the side effects. A phase 2 trial, we're really determining how effective is this drug. And a phase 3 trial is we're taking this drug or regimen and comparing it to standard of care. Are they the same, or is one better than the other? And how to find clinical trials. Clinicaltrials.gov has all the available clinical trials, but the IMF has made it easy for you. Give us a call and we'll guide you, walk you through what might be appropriate for you. And I know there's a lot of barriers for patients enrolling onto clinical trials. I just want to dispel a few of the myths. I think patients are very scared they're going to get a placebo. Just note, in multiple myeloma, we do not give placebo unless standard of care is observation. So you will never get a placebo unless it's in addition to what standard of care is. Maybe you feel like I live too far away to the center to participate in a clinical trial. Many clinical trials might offer compensation for gas or travel, or even provide hotel stay. So inquire with the team and see what's covered. A lot of patients are scared that clinical trials are dangerous. There are any risks associated with any treatment, whether it's FDA approved or not. But being on part of a clinical trial, you have a whole team looking out for you. I like to describe it as a global team, really monitoring all your labs and really looking at your side effects. And before you even get onto a clinical trial, we do additional tests to make sure it's safe for you. And then finally, clinical trials are expensive. You will never be billed for anything that is not deemed standard of care. So anything research related, the research program will pick up those costs. And then sadly, we do have an underrepresentation of minority patients in clinical trials. And it's really important to enroll all patients onto clinical trials, because certain drug effects might challenge people differently. So different ages, different races, it might affect them differently. So I think that is my last slide, and I'm sorry I went through that fast, but I know we're limited on time, so I'm happy to take any questions. Thank you.
Very comprehensive, Donna. Thank you. And many of you might have heard earlier, this is all being taped, so you can go back to it and look at our individual slides and slow down a bit. Now we're going to do some question and answers here. I'm going to talk. We get a lot about neuropathy. You already covered that. How about CBD for pain or other symptoms that, whatever it is?
So, it can help patients. And I know it's legal in a lot of states now. But, we can recommend it for certain patients that may benefit from it. So I don't necessarily discourage it, but just make sure you are very truthful to your team on the schedule and how often you're doing it.
Good to hear. All right, a patient is asking about, Amrita, I think you spoke about this, about the drugs that affect fingernails.
That's called talquetamab, and it's a direct target effect of GPRC. It can cause pitting in the nails. It can cause people to lose their fingernails. There's really only you can do is sort of topical therapy. The other thing we commonly see is people get peeling of their hands and soles of their hands, soles of their feet and palms of their hands. For that, we use steroid cream. The fingernails, there's not much you can do. People lose their fingernails. People have, just if their nails become more brittle, use clear nail polish and things like that just to try and protect them. Okay,
that's something you definitely have to pay attention to. COVID, is Paxlovid safe for multiple myeloma patients? Anyone want to take that? Caitlin?
Yeah, I can make mention of it. Yes. The biggest thing about Paxlovid is drug interactions. So we, for example, at UCSD have a pharmacist that helps us with this, because your drugs need to be cross-referenced with Paxlovid, every single one, because it can make some of your drugs more or potentially less potent, which can cause increases and changes in your side effects. So yes, I think Paxlovid can help people's symptoms improve or shorten over time, but we really need to make sure that all your medicines are being looked at.
Yeah, I agree with that 100%. Okay. Is it true non-secreting MM patients are not able to participate in clinical trials because there isn't a way to track their disease?
Unfortunately.
Yeah, Caitlin? Oh, okay. No, that was an easy question there to answer.
I think it's not fair, but Donna's right. Yes, it's unfortunate. I mean, I think these are patients who sometimes need, who always need access to these cutting edge drugs just as much as anything else. But as you can imagine for clinical trials, they're really trying to prove effectiveness. So if you have no means of quantifying the amount of myeloma that is deemed to be accepted across the kind of international myeloma working groups, there's no way of saying you had this much myeloma and it went down to this much myeloma. So that's the trouble.
Okay. Why is daratumumab left out of the CARTITUDE-5 trials? Is there a particular reason for that? Anyone? Is that what's happening?
I have to pull up CARTITUDE-5. I don't even remember which one that is. There's so many.
Okay. I understand.
I think it probably has to do. I'll pull it up right now, and so I can remember. But
I don't know how you remember. You guys remember what you all do remember.
CARTITUDE-5 phase 3 frontline.
You're right on the spot. We answer your questions. That's what's unique about the IMF. These are actual questions from the audience, and I'm doing my best to relay them. This is something that's important, and you'll hear these questions.
Oh, sorry, Kelly, because the question is why no DARA? Okay. Because DARA plus RVD is not an approved regimen yet. It's only, that is actually still in trial. So they use their standard of care, which is still just the 3 drugs. That's why.
We have, is daratumumab usually used as the first treatment? The person is kind of confused on what they're going to do for them. What do you think about that?
I think that's the kind of target that's moving a little bit, but a direction that we're heading in is it has not, at least in the last many years, been used in the upfront setting, but now we're starting to see more and more data come out that shows its effectiveness, and it's starting to get harder and harder to ignore that. And so I think many of us are starting to incorporate it into our initial cocktail when patients are first diagnosed.
All right, this is an interesting one here. My oncologist is stumped about one of my symptoms. Where do I go for help? Is it okay to get a second opinion?
Always okay to get a second opinion. I like to think that many of us don't have egos. So I think many of us want as many people thinking about you as possible. This is hard. I think it depends on what the side effect is or what the symptom is to know who the right person is to help you with that. But ask for help wherever you can find it.
Yeah, and that kind of goes back to our website, myeloma.org, the info line. The doctors that are out there to help, I'm not sure if you're in Southern California or Northern California or wherever you are. There's a lot of doctors on the West Coast here, so you can get answers. You're just really stress this. You're not alone with this disease. It's very important that you keep that in mind. And as doctors and nurses say, it's not a sprint. It's a marathon, and we have a lot of patients out there that are 15 and 20 years plus because they took a lot of things to help you out, but they also paid attention to how to take care of themselves.
I'm still stunned by the Donna comment, $50 a day for parking. That's so un-Californian.
New York City, baby.
Well, that's not even counting the tolls and the tolls on top of it.
It can cost patients $100 a day just to come in, and you can imagine patients are coming in multiple times a week. The costs add up, so it can be very expensive.
So free parking at City of Hope and probably UCSD,
or at least not 50.
They might even have valet there to park your car. Who knows? And let's end it with this one. Do many multiple myeloma patients also have amyloidosis? Yeah.
I'd say not many. I mean, it's probably about 10 to 15%. It's probably more than we think. We just don't always look for it because it doesn't necessarily change our management unless someone has symptoms directed to that. But if you find incidental amyloid in a bone marrow, for example, unless someone has something suspicious about it being in the heart, in the kidneys, then it's a little different story.
I see.
But it's not that common.
Oh, this is one other question. I'm sorry. If a myeloma patient tests positive, do you recommend test positive for COVID, Betelovimab? It's Betelovimad. That one, I have no idea what that means.
So this is the answer to the question is going to depend on where you are and what strain of COVID is prevalent in your area. So that is a form of a monoclonal antibody that is being directed hopefully towards some of the Omicron variants. So like, for example, at UCSD, Paxlovid is our first line right now. Remdesivir is our second line right now. And then the monoclonal antibody you just mentioned is the third because it does not target our current strains as well. So your area should have the best information about what their first, second, and third line against COVID, for treatment should you get it is.
Yeah, that's an interesting one. But we're down to time right now, and as I said, thank you so much for taking a Saturday off to help out a lot of patients out there. And you'll also notice that when we do record this, and so many people look at this after. We put it on this program with 10 different nurses and 20 different doctors, and we feel that it's a great educational series. So do take a look at it. We want to hear from you. Your feedback's incredibly important to us. If we don't get your feedback, we don't know how to guide the program structure. So take a minute, answer the question, whether it's good or bad. I don't care. Answer them. It's just going to take a couple more minutes of your time. Now, I like to also state to people that this is being recorded. You can go back to it at any time. You can go slow, fast. You can just listen, or you can go to the slides. But just remember that this is for you, and it comes as a benefit of sponsorship from Amgen, Bristol Myers Squibb, GSK, Janssen, Karyopharm, and Takeda. With all that being said, thanks, everyone, and have a fantastic Saturday.